Horses, what is the evidence? So it's a subject we're all familiar with. So again, what we're hoping to cover in this talk is general information on bleeders. What are the potential causes? What's the current thoughts on what is causing bleeding in horses? And again, looking at the effect in performance. And that's a really difficult one. We'll spend a bit of time, I think, on that. So we're all familiar with the disease. Or the condition. It's a condition that we see in horses that are exerting themselves, usually at high speed. Thankfully, it's a rarity for us to see epistaxis, but occasionally we will see horses with nosebleeds, blood at the nostrils, but more commonly it's something that people would rely on, again, endoscopy, post-racing endoscopy, to identify, but that's by no means the only method of identification. It's not a new condition, it's been recognized for centuries. Bartlett's Childers, bleeding Childers, was a son of the Arabian Darley, a full brother to Flying Childers, who some people still say holds the record for the mile. Bleeding Childers didn't really race as far as we're concerned, but he was a very successful breeding stallion, and that's back in the 1700s. And he was given that name largely because he probably was a case of EIPH. What is a concern to the racing industry? Well, the high prevalence is a big concern, obviously. Reduced short-term performance, we'll spend a little bit of time looking at the evidence for that. Lost training days, potentially. Requirement for pre-race medication in some countries, certainly. Racing bans, and I think a big one is public perception, that nobody likes to see a horse like this, even in the winning enclosure, with blood coming down the nostrils. So the public perception is a major issue that we can't ignore. It'd be wrong to do so. What about the prevalence? Well, again, it seems like a very simple question, a bit like the IED. It seems like a simple question to address, but it's not so simple after all, because it largely depends on the type of exercise the horse is doing, the population of horses that we're looking at. A big one would be the diagnostic criteria. So how do we define a bleeder? Is it based on the appearance of blood at the nostrils, or is it graded based on endoscopy, or do we take lung wash samples and assess it that way? And obviously the frequency of examinations. So just because a horse scopes clean on one occasion doesn't mean that he's not a bleeder on another occasion, and perhaps goes unnoticed. It's common during sprint racing. It's more frequent in thoroughbreds and standardbreds at high-speed exercise, more common in steeplechasers and hurdlers compared to the flat. They seem to be at a higher risk. But it is also recognised in other disciplines as well, but to a much lesser extent. Generally occurs during maximal exercise. Going back to what we were saying before on the definition of the disease, so there's a number of studies try to look at the prevalence of, or have looked at the prevalence of that, and if it's based on bleeding at the nostrils, that seems to range from 0.15 to 3%, and that's in thoroughbred racehorses. If it's based on endoscopic examinations, again this was on thoroughbred racehorses, on a single examination, depending on what study you read, between 44 and 75%, so very prevalent. And then if we up that to repeat endoscopies, in other words, it's not seen in one but it may be seen in another, then that prevalence goes up to 82 to 95%. And then if we're looking at valve cytology, in other words, we're collecting valve fluid from the lung of those horses, from the appropriate area in the lung, and then looking at it under the microscope and looking for evidence either of free red blood cells or previous evidence of bleeding, where we see those kind of iron pigment within the other cells within the lung, then about 100% almost that it's been found in comparison to less than 1% of endurance horses, which is a long duration, low intensity exercise versus a high intensity, low duration exercise. What are the risk factors? There have been numerous studies looking at risk factors, and I'll just try to summarize the main one there. So the big risk seems to be associated with cumulative measures of racing volume, depending on how that is measured. Now that might be the number of racing starts that the horse has had, it might be the duration of the racing career, or the number of years racing, And even age has been put into that category as well, and there is an association with the age of the horse, but that association with the age of the horse, again, is probably a marker of the cumulative measure of racing volume that horse has been involved in, which in itself tends to suggest that this is a progressive condition, and we know it is a progressive condition, and we'll come on to talk about why in a second. A fairly recent study, this was a study that looked at over 100,000 horses, almost 2 million race starts, and they showed quite convincingly that there was also a proven degree of heritability within this disease as well. So what about the mechanism? We've gone right down to kind of microscopic level here. So effectively, this is an electron micrograph of, it's not actually a horse's lung, but it would look very similar to this. So this is the alveoli, the little air sacs, where the inspired air ends up and where gas exchange takes place with the capillaries in the pulmonary vasculature. And those capillaries run in these little divisions between those air sacs. Okay, so it's a very, very efficient system. So this would be a high power image of one of those. So we have a capillary here, we have the red blood cells within the capillary. This side, on this side, we're going to have inspired air. And I'm going to be referring to this kind of cartoon, if you like, throughout the talk at different points throughout the talk, just to kind of highlight the mechanisms that might be involved. But suffice to say, at this stage, this is the area that we're concerned about here. That dividing line or that division between what is effectively inspired ambient air and the pulmonary blood flow in the horse. To give you an idea of just how thin that is, so we have the alveolar air here, we have the circulating blood here. To give us an idea of just how thin this membrane is between that inspired air and the pulmonary blood vessels to allow efficient gas exchange, if we were to say that a red blood corpuscle was the equivalent size of a family saloon car, then at its narrowest point, without breakage, then the size of the wall or the thinness of the wall that divides that from inspired air could be as wide as a beer bottle. So which kind of makes sense, because it has to be thin enough to allow efficient diffusion of oxygen in one direction and carbon dioxide in the other direction. And it may well be that the thinness of that particular wall, it's effectively a double-edged sword. It's thin enough to allow efficient gas exchange, but it's susceptible to certain forces that might be acting upon that might allow it to rupture. So again, going back to that cartoon there, in the steady state, then obviously what prevents blood from getting access into the airway is entirely dependent on the integrity of that dividing wall, that alveolar capillary division there. But obviously, we're dealing with live animals here, and there's pressure forces on either side of that wall that will be acting in different ways. So as we all know, the pulmonary vasculature supplies blood to the lungs from the right ventricle via the right atrium, and that blood, in order for that blood to flow, there has to be a pressure differential between one side of the pulmonary capillaries and the other side to allow flow to occur. And there, as a consequence of that, there's going to be positive pressure on that side of the equation, if you like. Similarly, when we look at the other side of the equation and we're looking at inspired air, you and I and horses breathe in exactly the same way, that we expand our chest, we push the diaphragm back. That creates a negative pressure during inspiration within the lung and within the individual alveoli, and that pressure differential from ambient pressure then results in airflow into the lung, and then in the resting horse at least, expiration, we just have relaxation of the lung and that air is forced out again. And what does that mean? Well, it means on the other side of the equation we have negative pressure. So we have positive pressure on our vascular side, and we have negative pressure on our ventilation side. And the net result of that is what we call a transmural pressure, a pressure against that wall that is heading in that particular direction. So again, this would be in the resting animal. But then if we look at the horse at exercise, then things change a little bit. So at exercise, we have a 30-fold increase in minute ventilation. That's the volume of air that goes in and out of the lungs over a 60-second period. We have a 10-fold increase in respiratory rate, which obviously is coupled to the stride. We have a 3-fold increase in tidal volume, a 20-fold increase in peak airflow, reaching at some levels 90 litres a second. So that's massive. And then when we look on the other side, and the cardiovascular side, we have an overall increase in cardiac output up to 300 litres a minute. So that's a 10 to 12-fold increase in pulmonary blood flow alone. And what's the net result of that? Well, the net result is we have an increase in the positive pressure, we have an increase in the negative pressure that's driving ventilation, and therefore we have an even greater pressure working across or moving across the wall between vasculature and inspired air. So what does that explain? Well, it probably explains the high prevalence of this particular condition in horses at peak exercise. It certainly explains the association with speed, why it's something that we generally, not exclusively, but generally see in association with exercise. What it doesn't really explain the biological significance. What is the biological significance of a horse bleeding into his airways when it's trying to run away from a cheetah, or a zebra running away from a cheetah? Why would it bleed into its airways? And hopefully we'll address that question a little bit later on. It doesn't seem to make biological sense. And it also doesn't explain why some are affected more than others. Why are some horses get a higher grade of EIPH compared to other horses? Another point that we can't forget is that there was certainly some really nice work done a number of years ago that showed that the pressures across that wall, those transmural pressures, are not likely to exceed breaking point in the normal exercising horse through a number of calculations. And one of the reasons, probably not the only reason, is the recruitment of additional capillaries within the lung that normally would not be perfused with blood, but are perfused with blood during exercise. That effectively reduces the load within the vascular component of that equation. And there's probably other contributing factors as well during exercise that lead to bleeding. Now, what might they be? Well, again, if we look on the right-hand side of the equation, if we look at ventilation, the factors that are commonly associated with bleeding would be factors that result in an increase in the subatmospheric pressures that have to be created within the thorax in order to allow airflow to occur. And these are factors that would generally be associated with a reduction in the caliber of the upper airway. So as a general rule, most of the airway is held open either by cartilaginous rings or by a bony column within the nasal cavity, but that's not true of the larynx, as I'm sure you're well aware. So that's the one area where we can get a reduction in caliber resulting in increased subatmospheric pressures generated to create an airflow, or at least prolong the period whereby those subatmospheric pressures are having an effect at the level of the alveolus before that airflow equalizes those pressures, if that makes sense. So there are respiratory conditions that might theoretically certainly lead to an increased propensity to bleed. And then if we look at the vascular side as well, then there's a number of theories that have been put forward. If we consider the heart, so this heart showing the left ventricle and the left atrium, so the left atrium receiving the blood from the pulmonary vasculature at this level here. And some of those theories that have been proposed over the years have been perhaps as a problem in the left ventricle, just an inherent problem that left ventricle cannot relax quickly enough to accommodate that blood flow that's required to pass into the left ventricle during exercise. So it's got probably about 1/8 of a second to fill during exercise at peak speeds, and it may well be it just doesn't have the capacity to do that. And therefore the consequences of that would be an increase in pressure within the left atrium, so a bit like having a hose pipe that you turn the tap on and you stand on halfway along the hose and you get an increased pressure between the tap and where you're standing. Another proposal has been at the level of the valve between the left atrium and the left ventricle. If there's some valvular regurgitation when that left ventricle contracts, instead of it passing up into the aorta, perhaps as a regurgitation of flow back into the left atrium. Again, same result, that there might be an increase in left atrial pressures that are then resulting in increased pressures downstream, upstream from that. These are just hypothetical things that have been proposed, really. Another one was in the left atrium itself, maybe the driving pressures in the left atrium. Now, under normal conditions, the left ventricle is effectively going to largely, not exclusively, fill passively. So that left ventricle will relax and the blood will flow through that valve from the left atrium, and then the left atrium will contract and push the remainder of the blood into it. There's not enough time for that to occur during exercise with heart rates of around 200 beats per minute, in which case the active component of left ventricular filling is very much heavily relied upon, and it may well be that those driving forces created by the left or relied upon by the left atrium are insufficient to allow that to happen. Again, a bit like standing on the hose pipe. But I would say of all of those theories that have been put forward, the one that sort of trumps all of those, certainly at the moment, is this theory whereby the problem might actually be within the vasculature in the lung. Again, still downstream from the pulmonary capillaries, but not at the level of the heart, at the level of the veins or the venules within the lung itself. And some really interesting work fairly recently has come out of, again, Michigan, the vet school in Michigan, by Kurt Williams, who back in 2008, he's a pathologist by trade, a veterinary pathologist, but he noticed histopathologically when he was looking at the lungs of horses with EIPH, he was noticing this kind of picture here, where this is effectively a vein of a horse, a pulmonary vein of a horse or venule of a horse, where the arrow is pointing to the lumen where the blood should be flowing. And for comparison, this would be a normal case here. So there's a significant reduction in the caliber of that vein, which raises the question, why was this never seen before? And one possibility is these were erroneously regarded as the thicker walled arteries or arterioles that you would expect further upstream from the capillary bed. But with particular staining, they showed that these were actually veins, and those veins had a very thick wall and a very narrowed lumen. So they proposed at that time that perhaps that had something to do with the underlying mechanism in EIPH. And they went on and embarked themselves upon a much, much larger study that was published in 2013, where they looked at 10 bleeders and 8 control horses. This was a post-mortem study. They meticulously looked at more than 2,500 samples obtained from those lungs from those horses at very specific areas within the lung. And the two questions they asked themselves was, does this remodeling, this what they call veno-occlusive remodeling, so that thickening, if you like, and narrowing of the veins, does that follow pulmonary blood flow distribution? And the answer to that question was yes. And the other question was, does that remodeling, where they see that remodeling anatomically within the lung, does it underpin the development of other EIPH lesions? In other words, is there evidence of bleeding within those areas? And the two things that they looked at were the presence of hemosiderin, this iron pigment that we talked about, and also scar tissue. And the answer to that question was yes as well. So it seemed to be that the distribution of that abnormality that they were seeing was in exactly the same site where those horses have a propensity to bleed from, which is in what we call the dorsal column at the top of the lung near the back of the lung. So again, going into this point here, why might that happen? Well, one reason why that's been proposed to happen is that it's just a normal response to sustained periods of increased pulmonary pressures during exercise. And that, I guess, is the bad news if indeed that is the case. In other words, why would that vein remodel to the point that it gets narrowed and thicker walled? Well, it would do that if there was a sustained increased pressure. What would cause a sustained increased pressure would be exercise. And it answers a lot of questions as to why this is a progressive disease. In other words, the more we train those horses at high speed, the more likely they are to develop this veno-occlusive remodeling. The more veno-occlusive remodeling they develop, the more likely they are to bleed downstream of that, or upstream of that, I should say, if that kind of makes sense. So it becomes a bit of a vicious cycle.
This could be a stupid question, but did they ever try that? I mean, I know they found that dead horses, so they can't, I guess. But it's like humans. Can you give them an aspirin and see if that makes a difference?
There's been a variety of drugs that have been used. John will, maybe we might not cover aspirin, John, but a variety of drugs that have been used in It's not so much to do with the coagulability of the blood. It's not like the blood is coagulating there. It's more that vein is under, well, the assumption is that exactly, it's been exposed to pressures and the way in which it responds anatomically to that sustained increase in pressure is to lay down more smooth muscle around it, and it becomes thicker and narrower. Yeah, that can make sense. So moving on to so that's the current front-running theory, and personally, I think it's the one that holds more water than any other theories that have been put forward over the years. Although there's always going to be exceptions to that. There's a number of reasons, other reasons why horses would bleed at exercise, but I think that explains a lot of them and a lot of the history of those cases. What about the effect on performance? Well, again, there's conflicting results on this, and I guess one question that we probably could ask ourselves, I'd be interested in just a show of hands actually, that if you had 100 starters, what is more likely? Would you think that you would see more bleeders in the top finishers? Would you see more bleeders in the bottom finishers? Or do you think they'd be equally distributed? So hands up for the top finishers. Pardon? Oh no, you're getting too technical now. Listen, say it was a mile sprint for argument's sake. Any show of hands for the top finishers? Yeah. Okay. Okay. Bottom finishers? Okay. Equally distributed. Okay. Right. So again, I mean, I don't know the answer to that question, but I think it raises. It raises.
Didn't the South African? There was a South African study that showed there were more.
Yeah.
In the bottom finishers.
Yeah. I'm coming on to that because it depends, I think, on this question here. And going back to the mechanism and that double-edged sword associated with the thinness of that membrane. And I guess the question is, and I'm conscious of the fact that I've got an epidemiology guru in front of me here, but are the inherent likelihood of bleeding and the inherent likelihood of winning, are they actually independent variables or not? Are they in any way related at all? And if you look at this graph here, and again, this is just pie in the sky thinking here, but if you had a graph that related those perfectly, so you've got, as the inherent likelihood of winning increases, the inherent likelihood of bleeding increases because you've got a more efficient diffusion of gas, okay? Probably not the case at all, but if it was the case, you potentially could have quite a marked difference between two horses, the one in green and the one in brown there. But the problem then exists, as we've already said, with the mechanism of how this disease or condition develops and the fact it's a progressive condition. Over time, if that were the case, that particular horse is ultimately going to have a reduction in his performance the more he bleeds, and therefore the difference between those two becomes less. And I think that's one of the potential reasons why that is actually a very, very hard question to answer. If it's an improperly conducted study. So let's go on and look at the evidence. So Ken Hinchcliffe in Australia in 2005, I'll just summarize his data there. So he showed that EIPH severity grade 2 or more, so the higher the grade, the worse the bleeding based on endoscopic scoring. They were 4 times less likely to win. They were 2 times less likely to win or finish in the first 3. They finished significantly further behind the winner than racehorses with an EIPH grade less than or equal to 1. In other words, they didn't have EIPH, or they had a very low grade of EIPH. They also showed that EIPH, bleeding severity less than or equal to 1, or 3 times more likely to be in the top earners group. Now that included horses that weren't bleeders, okay? So again, that suggests that yes, there is an effect on performance, certainly short-term performance. And then the study that Celia was referring to there, the Morley study out of South Africa, again, they showed that EIPH severity grade 0, so in other words, they weren't bleeders, versus more than or equal to 1, in other words, they were bleeders. They were twice as likely, or twice more likely to win races. These are the non-bleeders versus the bleeders. They finished an average 1 length ahead, and they were 2.5 times more likely to be in the top earners group. Okay, so again, fairly convincing evidence that it can have an effect in performance. But then when you look at the grade of bleeding here, so this is from the Morley study in South Africa, this is taken directly off their paper. And these two graphs here, the one on the left shows the odds ratio of winning compared to horses without EIPH. And these were the different grades. And this was the combined grade, so bleeders irrespective of what grade it was. And this was your reference point here, that you can see that the grade 1, the grade 2, the grade 3 sit along a fairly steady line there, and then once you get to grade 4, then that significantly drops. Okay. Again, when you look at the graph on the left-hand side there, your right-hand side, this is lengths finished behind the winner. Okay, so this was non-bleeding horses on average, 2 1/4 lengths behind the winner. Grade 1 to 3, a little bit more. Grade 4, significantly more again. So it wasn't just a case of whether the horse is a bleeder or not, it's how severe that bleeding seems to be. But there was certainly, I think, enough evidence, or is enough evidence, to show that there's a confirmed association with reduced short-term performance in those horses, but it is, or it seems to be, grade dependent. What about long-term performance? This was a study from Sullivan out of Melbourne in Australia, and this was based on a single endoscopic examination in those horses. So they defined those horses as either being EIPH positive or negative, and then they graded those horses as well. And this was a prospective study, so they gathered information prospectively throughout the racing career of those horses, and then they analysed that, and they present the results either from the time of endoscopy. So the horses have only been scoped once, okay? So they've been scoped once, put into those different categories, and then followed through. And the data they present is either from the time of that scoping, or even going further behind that time period, in other words, looking at their performance throughout their entire racing career. And again, this is just a summary of some of the results they showed. So this one here shows earnings after endoscopy. So the top 2 graphs are after the endoscopic examination, which categorized them into bleeders or not bleeders and what grade. And this is a lifetime career of those horses, so including time prior to their endoscopy. And again, looking at the earnings after endoscopy, we can see with grade 0 here, grade 1, grade 2, grade 3, and then a sudden drop with grade 4. Okay, quite variable data, but a drop with grade 4, and that was the only significant grade. If we look here, it starts after endoscopy, so that's the number of starts. Again, EIPH grade 0. Remembering this is based on a single endoscopic examination, 1, 2, 3, and then drops with 4. And then if we look at the lifetime career, again, the significant findings I've highlighted in red there. So this is lifetime wins, again, significant effect at grade 4. Lifetime placing, significant effect at grade 4. And lifetime starts, significant effect at grade 4. So the grade of EIPH, I think there's pretty convincing evidence as far as the long-term performance of that horse is a significant factor, not necessarily where it's a bleeder or not. Preston and colleagues did a study addressing a similar question, but in quite a different way, and this was out of Hong Kong. So these were horses that had multiple endoscopies, so that's one way in which it differed. So it wasn't based on a single endoscopic examination, and it was a retrospective study. Okay, so those horses, so they had access to that data. They looked at the scope findings from those horses on multiple endoscopies, and they also retrospectively looked at their performance. And again, positive or negative, bleeders or not, and what grade were they. They look at a lot of the data I'm going to present here is based on whether they had epistaxis. I think it's fair to assume if they had epistaxis, they were a high-grade bleeder. They were endoscopically examined, and they were determined to be a bleeder. They were endoscopically examined and determined not to be a bleeder. All of the scopings that they underwent. And the last group, which we'll kind of ignore, is no endoscopy was performed at all. So we don't know whether they're bleeders or not. And again, there's a number of data points from that particular study, but this is the one I want to kind of highlight. I've summarized some of the ones up on the top that will not show the graphs for, but they showed that EIPH positive horses, the number of starts in Hong Kong, so their entire career wasn't necessarily in Hong Kong, was not significantly different from EIPH negative horses. Okay, so there was no obvious difference in starts. So these were just positive, nothing to do with grade. Mild grade horses, grade less than 3, more likely to be retired for other causes, and severe grades more likely to be retired for EIPH, which you'd kind of predict to a certain extent anyway. But what's really interesting is when you look at the career, the length of career of those horses. So let's ignore the ones that weren't scoped. We can't really say anything about those, the ones in brown. But if we look at the ones that had no EIPH, okay, so they were scoped on multiple occasions, not always the same number of occasions, but they're in red there. So we can see as the graph comes down like that, this is a gradual drop-off of horses throughout their career, okay? So it runs down like this. And then we compare it to horses that had EIPH. And if you look at the blue line there, you can see that the longevity of their racing career was actually greater if they were EIPH positive versus EIPH negative. Okay? And then the ones that had epistaxis start off that way, and then the lines cross over. So they start off having a more prolonged career, but as we said, this is probably it is a progressive condition, and it probably reached a point in those horses, then there was a tail off in their career. Okay? So it's not a simple yes or no answer, I don't think. And then just very quickly, when we go back to that previous Australian study, the one that looked at the heritability of this condition, slightly different data. So this is looking at occurrence of epistaxis, whether the horse had a nosebleed or not. Either it didn't have a nosebleed, it had a nosebleed on one occasion, or it had a nosebleed on 2 occasions, and we see a similar pattern. So first of all, looking at the blue curve there, horses that did not have any evidence of a nosebleed, one episode of a nosebleed, then it's lying to the right-hand side, so that there seems to be, certainly throughout some of that curve, there's a prolonged career in those particular horses, but then if they have 2 or more nosebleeds, then there's a crossover in those. Okay, so again, it shows it's the severity of the bleed that seems to have an effect on the long-term performance as well as their short-term performance. And again, I think it comes back to this point. Are there inherent likelihood of bleeding, inherent likelihood of winning independent variables? Well, no, they're probably not independent variables. They're probably related in some way, but they're intertwined to such an effect with a progressive disease that as that horse bleeds more and more and more and more, then his performance is ultimately going to drop off. So what are our conclusions? That EIPH occurs largely as a result of increased pulmonary capillary pressures. We've known that for decades. The pressure increase in response to vascular remodeling, certainly if that Michigan theory is right, and it certainly holds an awful lot of water, is probably a response to repetitive exposures to high pressure during training. Okay, so you're into this kind of vicious cycle. This was a set of lungs from a horse with EIPH, and as you can see, normally the bleeding would start here. So this is the front of the horse, this is his windpipe here, this is the back of his lungs that lie over quite near his kidneys. This is the start of the bleeding here, and as time goes on, it probably progresses in a more cranial forward direction. It is a progressive condition. There's a detrimental effect on short-term performance, that's been shown, and a variable effect on long-term career, which is largely grade dependent. And again, it goes back to that question as to whether there's a relationship between those inherent qualities. So I'll finish there. Thank you.